Thank you. So I'm going to be taking the role of Onaiza in a minute to talk about the Pakistan study. So I'm going to start by general acknowledgements. All of our research was funded by the NIHR. As Stefan mentioned, we're part of a big global group. We've added the acknowledgements here so that we don't have to do that for each and every slide. But please just bear in mind that all of this work was funded as part of the NIHR group. I'm going to be presenting this on behalf of Onaiza, who sadly couldn't be here today. What we're going to be talking about is a small-scale study that we did in Pakistan, particularly in Karachi, with our new partners, and how this led to an even bigger collaboration. So, although the group in general focuses on severe mental illness, we had some scope with some of the extra funding to focus on other areas of mental health care. And we know that in low and middle income countries in particular, common mental disorders are a big problem. Around 10% of the world suffer from common mental disorders such as depression and anxiety. But in low and middle income countries, that prevalence has been estimated to be around 20 to 40%. And we have estimates from Pakistan that particularly for women, up to 50% of the population may have some form of disorder. Yet 90% of people across the world, and particularly in low and middle income countries, have untreated common mental health disorders. And where care is provided, it may often be low quality or substandard. We know that the minimum level of care which people have called for often doesn't happen in many countries across the world. And part of this may be a resource issue. For example, in Pakistan, there are around 500 psychiatrists in the country for 220 million people. So if we take a look around this room at the moment, there's 100, 150 of us. So we've nearly got the entire population of Pakistani psychiatrists in one room. And just to bear in mind to say that again, for 220 million people. And overall, we may moan about our spend on the NHS and on mental health services, but in Pakistan, only 0.4% of the budget is spent on mental health. So this means that we need to look at alternative ways that we can treat and help people within the community and utilize some of the fantastic resources that we have. And one of those fantastic resources is the family. So we wanted to explore the use of trialogues, which bring together families and professionals and people with experience in mental health problems as a resource-low way and a resource-oriented approach that we could help people overcome mental health problems. So we did this in a very small open scale study. So it's around 40 patients. And we were particularly focused in an area called Karanji in Karachi. And that's an area which is low income and very urban. So it's in the center of the city. And we used trialogues, which involved bringing service users together with their carers, but also with sort of hosted by a mental health professional. But what's key in trialogue is that the sessions are co-produced. And I feel we use that word far too often. But here we mean that it was the families, it was the people with lived experience that say, no, today I want to talk about this. Next week, I want the session to focus on this because this is what I need. And people met monthly for about 6 months. So what did we find? In total, we had 29 people who had experience in mental health problems and 31 caregivers who regularly attended these 6 sessions. And these were in smaller groups of around 5 to 6 patients per group. And the results quite literally blew us away. We found that quality of life not only improved, but it improved on an effect size of a magnitude that we very, very rarely see in psychiatry anywhere in the world, an effect size of 2. And this is something that I want you to bear in mind when we hear the other presentations. So to answer the question, was this a one-off or is it something about low resource settings and resource-oriented interventions? But it wasn't just quality of life that's improved. We also had a substantial effect on symptoms measured by the Aga Khan University Anxiety and Depression Scale. Objective social situation improved and caregiver burden. That was the only finding we found that actually caregiver burden didn't really change. So even though people found this intervention really helpful, carers still felt that there was a burden, but the burden was a different type of experience. So what did people say? So it's really interesting, some of the quotes that we got from some of our qualitative work. But people talk about how it changed the way they saw themselves, and it changed the way they interacted with members of their family. So I'm not going to read these out, but I'll just leave them here for a little while. But just to pick up on a few points, that the idea of how people saw themselves as a crazy person, and how that was changed by meeting other people with similar experiences, or how family members felt that it was actually a relief to be able to talk with other family members and to learn new skills. The second intervention that we looked at was Dialogue Plus, something that we know, particularly in East London, we're quite familiar with. So we wanted to see if this would work in primary care services for people with anxiety and depression. So again, we did an open control trial. So we had a number of primary healthcare clinics, and we recruited around 40 individuals who experienced anxiety and depression. Crucially, we used lay counsellors. So these are people used within services who do not come from a medical background, but receive minimal training in different types of interventions. So we trained people over 2 days. A number of colleagues from the UK, and working with our colleagues in Pakistan, trained researchers in a 2-day training event. And when we look at what was done over the 6 months, we found that on average in each session, 1 to 2 items were covered. And interestingly, we've done dialogue studies across the world, and it's always the same 3 areas that people want to discuss: mental health, physical health, and job situation. So what did we find? Again, it looks like the first result wasn't a fluke. We had massive effects on quality of life, a 1.6 effect size, massive effects on symptoms, and also our social situation improved. But the numbers don't speak loud enough. We also asked patients and staff members how they felt. And again, people found that it was a way that they could really come to see their progress, come to see different areas of their life. And it provided structure for the lay counsellors to be able to work with people with anxiety and depression. So I'm just going to leave this here. And just want to close by saying it was a really eye-opening experience to be working with lay counsellors, because out of everybody, the lay counsellors really felt that this could benefit people with anxiety and depression. They talked about how it gave them structure to be able to talk to people with only very minimal training, and they felt it could really, really have an impact on the lives of people. So we're currently taking this up further, and we're doing a large-scale cluster RCT in both India and Pakistan, where across both sites we now have 420 people with psychosis that are going to be receiving Dialogue Plus, because we have such a will to work with the clinicians out there. People really, really want to have these interventions. So I'm hoping in about 2 years' time, I'm going to be standing up here with my colleagues from India and Pakistan, giving the results of the PIECES trial. But thank you ever so much.